We're going to discuss some new data with LCZ696, sacubitril valsartan, from the PARADIGM-HF trial. So we're now looking at a lot of data from the study to try to understand who might most benefit from being on this drug. We get asked the question a lot, does this drug benefit patients who are doing reasonably well? I have patients who have heart failure, but they haven't been hospitalized recently. Is there some reason that I should think about switching their medication, which might be an ACE inhibitor or an ARB, to sacubitril valsartan? And so we looked at that in these patients. We defined patients as being more or less stable based on when they had a prior hospitalization for heart failure. And so those patients who had a hospitalization for heart failure most remotely or even never, and about a third of our patients have never had a prior hospitalization for heart failure. And of course, those patients have a overall better event rate than the patients who are hospitalized more recently, as you'd expect. But it turns out that there is no difference in the effectiveness of sacubitril valsartan based on how stable these patients are. In fact, when we talk about stable, it's really a misnomer, because our most stable patients, those people had never had a heart failure hospitalization previously, still had a 20% primary event rate during the course of the trial, and 17% of those patients died during the course of the trial. And the primary event in these people, that is the first event that they had, was death in about 50%, and it turns out the majority of those are sudden deaths. So if your strategy is to wait for your patient to decompensate, you're going to lose the opportunity in a large number of patients. We believe that these data suggest that we really should be thinking about taking patients who fulfill the PARADIGM-HF inclusion criteria and switching them from an ACE inhibitor or ARB to sacubitril valsartan. We saw a 20% reduction in overall cardiovascular death or heart failure hospitalization in patients who were randomized to sacubitril valsartan, even if they were the more stable patients. I think inertia is a major part of it. We get very used to certain medicines, and remember, we've had ACE inhibitors and ARBs for an awfully long time. They've been the cornerstone of treatment. So unlike many therapies we've had in heart failure, where we actually add something on top of what we're treating our patients with, in this case, we're replacing something that we're very comfortable with. And that I think is hard for people to do, but it's an inertia that we need to overcome for the sake of our patients. Well, I think once doctors realize that their patients will feel better because we have good quality of life data, their patients will stay out of the hospital, and obviously this is a major component of the cost of healthcare, and their patients will die less. I mean, we had an all-cause mortality benefit. So I think patients are going to demand this as well. We've also shown at this meeting that it's highly cost-effective. We presented data yesterday suggesting that it had a $45,000 was the ICER for per quality-adjusted life years. That's well under what the ACC and AHA and the World Health Organization say is highly cost-effective. I think we have to keep pushing on the data so that doctors out there know what the potential benefits are for their patients. There will be more trials. I can tell you that we're in the well over halfway through recruitment in the PARAGON-HF trial, which is heart failure with preserved ejection fraction with the same therapy, sacubitril valsartan. We're going to start in the end of 2016 a post-MI trial called Paradise MI. as well as lots of other smaller studies that will support the notion that there's benefit with this therapy, potentially with looking at new patient populations that we didn't study in the Paradigm HF trial.